You know that moment, right? When you're
Uh-huh.
just living your life, maybe slicing an avocado or opening a package and then utilizing a small cut.
Yeah.
Your first thought might be, okay, where's the Band-Aid? But have you ever truly paused to consider the absolute biological marvel that springs into action inside your body the very second that skin is broken?
Mm.
It's far from a simple drip and stop. It's an incredibly intricate, precisely choreographed dance of cells and proteins, all rushing to seal that tiny breach.
Right.
It's something we completely take for granted, yet it's quite literally a matter of life and death, happening automatically, constantly keeping us alive.
It truly is a testament to billions of years of evolutionary engineering. What seems like a trivial cut immediately initiates a cascading series of events, a rapid deployment of your body's internal first responders.
Yeah.
Without this immediate complex response, even the smallest injury would be catastrophic.
And that's exactly what we're diving into today on the deep dive. We're going far beyond just stopping a paper cut. We're taking a deep, deep look into the intricate world of hemostasis. That's the fundamental biological system that keeps us alive by limiting blood loss.
Right, the core process.
And critically, we'll explore how modern medicine, especially in a surgical context, interacts with and even manipulates these incredible systems. We'll cover surgical bleeding and, of course, the life-saving science of transfusion.
Our mission today, for you, is to gain a mastery-level understanding of this critical field. Think of it as gaining the insights that the elite professionals in this area possess.
Okay.
We're not just going to throw facts at you, we're going to unpack the why and the how behind them, equipping you to be truly well-informed about these complex nuances.
All right, let's unpack this then, starting with the very foundations of blood clotting, the biology of hemostasis itself.
So hemostasis, at its core, is the highly orchestrated process designed to limit blood loss when a vessel is injured. It's not a single event, but rather four major physiological phases that work together in a continuous reinforced process.
Right.
Think of them as the body's essential first responders, each playing a critical interconnected role.
And those four major physiological phases are vascular constriction, platelet plug formation, fibrin formation, and finally, fibrinolysis, which is essentially the cleanup crew.
Exactly.
What's so fascinating is how they work together in order, but also with multiple reinforcements, creating this incredibly robust, self-regulating system.
Precisely. Let's start with phase one, vascular constriction. This is the body's immediate reflex, the very first thing that happens when a vessel is injured.
Okay.
The smooth muscles in the vessel wall contract, causing the vessel to narrow rapidly. This response is more pronounced in vessels with a significant amount of muscle in their walls. And it's a crucial initial step to physically reduce blood flow to the injury site.
So it's like the vessel quickly cinches itself down. Is this just a general muscle contraction, or are there specific chemical signals involved?
It's definitely not generic. There are specific local vasoconstrictors at play, chemical messengers that drive this immediate narrowing. Key players include thromboxane A2, or TXA2, which is a potent constrictor produced directly at the injury site by activated platelets.
Right.
Then you have endothelin, synthesized by the injured vessel lining itself, and serotonin, released during platelet aggregation. These work together to rapidly constrict the vessel.
So the body has multiple ways to get that vessel to clamp down quickly. Does the extent of this initial constriction always look the same, regardless of the injury?
Not at all. It varies significantly with the degree and type of vessel injury. For instance, if you have a small artery with just a lateral incision, it might actually stay open due to the physical forces of blood flow, allowing continued bleeding.
Interesting.
But if a similarly sized vessel is completely transected, meaning cut straight across, it might contract so effectively that bleeding actually ceases spontaneously. It's quite remarkable how precisely the body responds to the specific damage.
All right, that's the immediate physical response. Let's move on to phase two, platelet function, which is all about building that first vital barrier. We hear about platelets all the time, but what exactly are they and how do they function?
Platelets are quite unique. They're not full cells. They're actually anucleate fragments, meaning they lack a nucleus, and they originate from much larger bone marrow cells called megakaryocytes.
Right.
In a healthy person, you'll typically find between 150,000 and 400,000 platelets per microliter of circulating blood.
Wow, that's a lot.
It is, and interestingly, up to 30% of these can be temporarily stored or sequestered in the spleen.
Okay.
If they're not consumed in a clotting reaction, The spleen also helps remove them after their average lifespan of 7 to 10 days.
So these are tiny, short-lived, yet incredibly vital fragments. What's their core job in stopping bleeding?
Their role is integral. They form the initial hemostatic plug, which is like a temporary seal for the injured vessel.
Okay, the first plug.
Crucially, they also contribute significantly to the formation of thrombin, the central enzyme in clot formation. Normally, platelets don't stick to each other or to the vessel wall. That would be problematic.
Right, you don't want clots forming all the time.
Exactly. But when vascular disruption occurs, that changes immediately.
That brings us to how they go from just circulating to forming this critical barrier, what's called primary hemostasis.
Yes. When the inner lining of a blood vessel, the intimal layer, is injured, it exposes underlying collagen. This exposed collagen is what platelets adhere to.
Ah, the trigger.
This initial adhesion process requires a crucial protein called von Willebrand factor, or VWF.
Von Willebrand factor, okay.
This VWF is found in the subendothelium and binds specifically to a complex on the platelet membrane called glycoprotein IAXV. This is why patients lacking VWF in a condition known as von Willebrand's disease have significant bleeding issues.
Okay, so that's the initial sticky handshake between the platelet and the injured vessel wall. What happens next?
Once adhered, these platelets initiate what's called a release reaction. This reaction actively recruits other platelets from the circulating blood to the injury site, effectively sealing the disrupted vessel.
Got it.
This entire initial process, from adhesion to the recruitment of other platelets, is known as primary hemostasis. It's important to note that this initial aggregation is generally reversible and doesn't involve the full secretion of substances from the platelets just yet.
Okay.
And quite importantly, heparin, a common anticoagulant, does not interfere with this initial reaction, meaning some degree of hemostasis can still occur even in heparinized patients.
That's a key point.
The principal mediators in this initial platelet aggregation are adenosine diphosphate, or ADP, and serotonin.
So we have this initial reversible plug, but then things get more complicated with chemical pathways. Can you explain the arachidonic acid pathway and how common medications interact with it? This seems like a really practical takeaway.
Absolutely. When arachidonic acid is released from platelet membranes, an enzyme called cyclooxygenase converts it into a series of prostaglandins, ultimately leading to thromboxane A2, or TXA2.
TXA2 again.
We already mentioned TXA2 as a potent vasoconstrictor, but it's also a powerful platelet aggregation agent.
Yeah.
Now here's where the body's clever balance comes in. Arachidonic acid can also be shuttled to adjacent endothelial cells.
Okay.
There, it's converted into prostacyclin, or PGI2, which is essentially the opposite of TXA2. It's a vasodilator and actively inhibits platelet aggregation.
Wow.
This creates a crucial counter-regulatory mechanism that prevents excessive clotting.
That's a sophisticated built-in brake system, and this pathway is precisely where many common medications come into play, which is super helpful to understand.
Exactly. Aspirin, for instance, works by irreversibly inhibiting platelet cyclooxygenase, which is why it has antiplatelet effects that last for the lifetime of the platelet.
For 7 to 10 days, right?
Right. Non-steroidal anti-inflammatory agents, or NSAIDs, also block cyclooxygenase, but their effect is reversible.
Oh.
Interestingly, the newer cyclooxygenase 2, or COX2, inhibitors do not significantly affect this pathway in platelets, offering a more selective anti-inflammatory effect without as much impact on platelet function. This is a powerful, practical example of how these fundamental biological pathways are targeted by drugs.
So we've got the initial reversible plug, but then there's a second wave of platelet aggregation. What makes this different, and how does it strengthen the barrier into something more permanent?
The second wave is where the plug really gets cemented and becomes irreversible. In this release reaction, activated platelets discharge a variety of substances they've stored, including more ADP, calcium ions, serotonin, TXA2, and even proteins from their alpha granules.
Okay, releasing the good stuff.
The second wave is crucial because it leads to irreversible compaction of the platelets into a strong, stable plug. Fibrinogen is a required cofactor here. It acts as a bridge for the glycoprotein IBA, or GP-IBA, receptor on the activated platelets, essentially linking them together tightly.
The glue.
Kind of. Proteins like thrombospondin, also secreted from the alpha granules, further stabilize this fibrinogen binding and strengthen those platelet-platelet interactions. These activated platelets also undergo critical changes on their membrane surfaces. These phospholipid alterations allow calcium and various clotting factors to bind, forming enzymatically active complexes, sometimes called platelet factor 3, that catalyze the formation of thrombin.
Okay.
Platelets also play a role in the initial activation of factors AF and 12, setting the stage for the next critical phase.
Which brings us to phase 3, coagulation forming the fibrin clot. Now, you mentioned that the traditional coagulation cascade model, which many of us might have heard of, is a bit simplistic. Can you explain that and then walk us through the traditional cascade before we get to the more complete picture?
That's right. Well, the traditional coagulation cascade model, often depicted as two distinct pathways converging into one, is incredibly useful for understanding the basic sequence leading to clot formation. It's an oversimplification. It doesn't fully capture the immense depth and complexity of the interactions, including the numerous feedback loops, the crucial role of the endothelium, and the intricate functions of platelets we just discussed. It's a good starting point, but not the whole story.
So let's start with the basics of that traditional cascade with those caveats in mind.
Okay. In this traditional model, we visualize two primary arms, the intrinsic pathway and the extrinsic pathway, both converging into a common pathway.
Intrinsic and extrinsic.
The intrinsic pathway is initiated by the activation of factor 12. This then sequentially activates factors 11, 9X, and 8. These factors are considered intrinsic because they're already circulating in the plasma. No external tissue is strictly required to initiate this pathway, theoretically.
And the extrinsic pathway?
That's initiated by tissue factor, or TF. TF is released or exposed on the surface of injured endothelium. It then binds to circulating factor 7, which facilitates its activation to factor T.
And where do they meet? The common pathway.
Exactly. Both the intrinsic and extrinsic pathways converge here. It all starts with the activation of factor X to factor Zia, which requires factor Eta.
Okay.
Subsequently, factor Zia, with the critical help of factor V, converts prothrombin, which is factor 2, into thrombin, or factor 2.
Thrombin, the key enzyme.
Thrombin is truly the star of the show here, as it then converts fibrinogen, or factor 1, into fibrin. The final crucial step in forming a stable clot involves factor 13, which assists in cross-linking these fibrin monomers into strong, insoluble polymers.
And this traditional model actually links up nicely with some common lab tests, which is helpful for diagnostics, right?
It does, which is one of its convenient features for diagnostic purposes. An elevated activated partial thromboplastin time, or APTT, is typically associated with abnormal function of the intrinsic arm of the cascade, specifically reflecting issues with factors 2, 9X, X, and 12.
Okay, APTT for intrinsic.
On the other hand, the prothrombin time, or PT, is linked to the extrinsic arm, primarily assessing factors 2, X, and X.
PT for extrinsic.
It's also important to remember that conditions like vitamin K deficiency, or the use of warfarin, directly affect factors 2, 7, IX, and X, which will be evident on these tests.
So the traditional cascade provides a good conceptual framework, but you mentioned a more complete picture about the cell-based model. How does that deepen our understanding, and what's the big difference?
The cell-based model offers a far more comprehensive and accurate understanding, dividing clot formation into 3 phases: initiation, amplification, and propagation.
Initiation, amplification, propagation.
This model really emphasizes the central role of tissue factor and the platelet surface in a more dynamic, physiologically relevant way. It's less about separate pathways and more about what happens on cell surfaces.
Let's break down those 3 phases. What happens during initiation in this cell-based model?
In the initiation phase, the primary pathway for coagulation truly begins with the exposure of tissue factor, or TF, following subendothelial injury.
Right, the injury exposes it.
This TF binds to factor A. This complex, TF-VA, then rapidly catalyzes the activation of factor X to factor A and factor 9X to factor ASA. Factor AXA, in turn, activates factor V to factor V. This prothrombinase complex then generates small initial amounts of thrombin from prothrombin. This early thrombin is just the spark.
So that's the initial spark. Then comes amplification.
Yes. During amplification, that small amount of thrombin generated in the initiation phase begins to activate platelets. These platelets adhere to extracellular matrix components at the injury site and become fully activated by thrombin and other stimuli.
Getting them ready.
This activation fundamentally changes their surface, making them ready for the next critical phase.
And the propagation phase sounds like where the real thrombin burst happens.
Exactly. In the propagation phase, two crucial complexes, tenase, composed of factor A, factor AKC, and prothrombinase, composed of factor V and factor A, assemble on the surfaces of these fully activated platelets.
On the platelets themselves.
Yes, that's key. This assembly leads to a massive, rapid generation of thrombin, what we call the thrombin burst. This burst is critical because it generates the large amounts of thrombin needed for widespread fibrin formation, which forms the stable clot.
Much more thrombin than an initiation.
Orders of magnitude more.
Huh.
It's also worth highlighting the impressive efficiency here. The factor eta combining with factor ISAR to form the intrinsic factor complex is 50 times more effective at catalyzing factor X activation than the extrinsic TFVIA complex, and vastly more effective than ISR alone.
Wow.
This redundancy and efficiency are built right into the system to ensure effective clotting.
Incredible. And once all that thrombin is formed, how does it actually create the fibrin mesh that makes up the clot?
Once formed, thrombin detaches from the platelet surface and performs a two-step cleavage of fibrinogen. This process removes two small peptides, fibrinopeptides A and B.
Okay.
The removal of fibrinopeptide A allows the fibrin molecules to polymerize end-to-end. The subsequent cleavage of fibrinopeptide B allows for side-to-side polymerization, which strengthens the fibrin clot.
Building the mesh.
Exactly. This latter step is facilitated by thrombin-activatable fibrinolysis inhibitor, or TFA, which acts to stabilize the resultant clot.
That's the formation. But the body also needs a way to make sure it doesn't just keep clotting indefinitely, right?
Well, absolutely.
There has to be a sophisticated way to regulate the clot, to prevent an overwhelming burden.
Absolutely. The body has several interrelated processes that prevent the clot from propagating beyond the immediate injury site, striking a critical balance between preventing profound bleeding and overwhelming clot burden.
Okay.
One key mechanism is feedback inhibition on the coagulation cascade itself, which deactivates the enzyme complexes that lead to thrombin formation.
How does that feedback inhibition work? What are the key players?
The endothelium, the inner lining of blood vessels, presents a molecule called thrombomodulin, or TM. This TM acts as a thrombin sink by forming a complex with thrombin, making thrombin unavailable to cleave fibrinogen.
So it neutralizes the thrombin.
In a way, yes. And this TM thrombin complex then has another vital function. It activates protein C, or APC. Activated protein C then reduces further thrombin generation by inhibiting factor V and factor VIII.
Okay, shutting down key factors.
Additionally, tissue factor pathway inhibitor, or TFPI, is released, which blocks the TFVA complex and reduces the production of factor SEA and factor ISA.
Right.
Another key regulator is antithrombin III, or AT3, which neutralizes all of the procoagulant serine proteases and also inhibits the TFVI complex.
So it's a multi-pronged attack on excess clotting. And I believe the APC system is particularly potent.
It is. The most potent mechanism of thrombin inhibition involves the APC system. Activated protein C forms a complex with its cofactor, protein S, on a phospholipid surface. This powerful complex then cleaves factor V and factor A, effectively preventing their participation in the formation of prothrombinase complexes and further driving coagulation.
And this brings us to a really interesting clinical relevance. Factor V Leiden. What is that, and why does it matter so much in the real world?
Factor V Leiden is a genetic mutation where factor V is resistant to cleavage by APC.
Ah, so APC can't shut it down.
Exactly. Because it can't be properly inactivated, it remains active as a procoagulant, significantly tipping the balance towards clotting. Patients with factor V Leiden are therefore predisposed to venous thromboembolic events, like deep vein thrombosis or pulmonary emboli.
Right.
It's a key aha moment, showing how a single genetic tweak can profoundly impact a fundamental biological process and translate directly to a significant clinical risk, potentially leading to dangerous blood clots.
So the body forms the clot, regulates the clot, and then there's phase 4, fibrinolysis, the cleanup crew that shores blood flow and maintains patency.
Exactly. Fibrin clot breakdown or lysis is essential for restoring blood flow during the healing process, and importantly, it begins simultaneously with clot formation.
Starts right away.
Pretty much. The primary enzyme responsible is plasmin, a serine protease derived from its proenzyme, plasminogen. Plasmin degrades the fibrin polymers, producing circulating fragments called fibrin degradation products, or FDPs, which are then cleared by other proteases or by the kidney and liver.
How is plasmin formed, and what are the main activators?
Plasminogen is converted to plasmin by several activators. Tissue plasminogen activator, or TPA, is made by the endothelium, and it's the main circulating form.
TPA, right.
What's crucial about TPA is that it's selective for fibrin-bound plasminogen, ensuring that endogenous fibrinolytic activity mainly occurs right at the clot site. It's also released upon thrombin stimulation.
Okay.
Another major activator is urokinase plasminogen activator, or UPA, also from endothelial cells, but it's not selective for fibrin-bound plasminogen. The trimolecular complex of TPA, plasminogen, and fibrin is incredibly efficient at cleaving fibrin.
And just like clot formation, fibrinolysis also has its own regulatory mechanisms to keep it in check, correct? We don't want it breaking down too fast or too much.
Yes, preventing excessive breakdown is just as important as preventing excessive formation. TPA activates plasminogen more efficiently when it's bound to fibrin, which helps ensure plasmin forms selectively on the clot itself.
Right, targeted breakdown.
Plasmin is also inhibited by alpha-2 antiplasmin, a protein that is cross-linked to fibrin by factor 13, acting as a brake to prevent the clot from lysing too quickly.
Okay.
Any circulating plasmin, TPA, or urokinase is also inhibited by alpha-2 antiplasmin, preventing systemic breakdown.
And what about that thrombin activatable fibrinolysis inhibitor, TAI, that you mentioned earlier? How does it play into fibrinolysis?
TA, activated by the thrombin thrombomodulin complex, has a nuanced effect on clot stability. It directly inhibits fibrinolysis, but it also makes the clot more susceptible to lysis by removing terminal lysine residues from fibrin, which are essential for plasminogen binding.
A dual role.
This dual role helps fine-tune the balance of clot stability and breakdown.
And what are the clinical implications of these fibrin degradation products, the FDPs? We often hear about D-dimers.
FDPs, which include D-dimers, are important markers. These smaller fragments can actually interfere with normal platelet aggregation, and larger fragments might be incorporated into the clot in place of normal fibrin monomers, which can lead to an unstable clot.
Okay.
This is particularly relevant in cases of severe coagulopathy, such as hyperfibrinolysis seen in trauma-induced coagulopathy or disseminated intravascular coagulopathy, or DIC.
Right.
The presence of D-dimers in the circulation is a valuable marker, often indicating thrombosis or significant activation of the fibrinolytic system, and it's commonly used to rule out conditions like DVT or pulmonary embolism.
That's a comprehensive overview of how things should work. Now let's transition to segment 2, when things go wrong. Congenital and acquired hemostatic defects. Before we dive into the specifics, let's hit some critical nuggets, some truly important takeaways for our listeners, the things that stick with you.
Okay, good idea. First, remember that platelets have a lifespan of only 7 to 10 days. This makes them highly susceptible to interference from common drugs like aspirin, clopidogrel, and the GP-IBOYA inhibitors.
Right, the irreversible ones especially.
Exactly. A general guideline for elective procedures is to stop these medications approximately 5 to 7 days beforehand to allow new functional platelets to circulate and ensure safe surgery.
That's a critical, practical point. What's another key takeaway?
Trauma-induced coagulopathy, or TIC, is a distinct phenomenon found in up to a third of severely injured patients right upon admission.
Right at the door.
It's crucial to recognize it's distinct from generalized disseminated intravascular coagulopathy, or DIC, and also from coagulopathy caused simply by hemodilution from resuscitation fluids.
Okay.
While several mechanisms are proposed for TIC, the precise relationship between the lab abnormalities we see and clinically evident coagulopathic bleeding can still be unclear, but it's a major risk factor for early death.
And what about the newer direct oral anticoagulants, or DOACs? They're very common now.
They present a significant challenge. Unlike warfarin or heparin, there's no readily available standardized method for monitoring the precise degree of anticoagulation with DOACs.
Which is tricky in emergencies.
Very tricky. This can make emergency management difficult. However, there has been progress. A new monoclonal antibody, idarucizumab, has been approved to reverse dabigatran, and several promising agents are currently in clinical trials for the reversal of direct factor NACI oral anticoagulants.
So when a patient is on anticoagulants and needs surgery, how do you decide whether to bridge them or not? That seems like a high-stakes decision.
It is a complex and highly patient-specific decision. When determining the need for bridging therapeutic anticoagulation in the perioperative setting, that is, around the time of surgery, physicians must carefully balance the patient's individual risk of bleeding against their risk of thromboembolism.
Bleeding versus clotting risk.
This careful risk assessment guides whether temporary reversal of anticoagulation is necessary preoperatively and when it can be safely restarted postoperatively.
What are the fundamental components of damage control resuscitation, or DCR?
Damage control resuscitation, or DCR, has three basic components. First, permissive hypotension, which means allowing the blood pressure to stay a bit lower than normal to prevent dislodging clots and limit further bleeding.
Okay.
Second, minimizing crystalloid-based resuscitation, meaning avoiding excessive intravenous fluids that can dilute clotting factors.
Right, don't dilute the good stuff.
And third, the administration of balanced ratios of blood products, specifically red blood cells, plasma, and platelets, mimicking whole blood as early as possible.
And finally, a key concept for any emergency situation involving significant bleeding.
It's absolutely vital to anticipate the need for massive transfusion. Hospitals and medical teams should have established guidelines in place to ensure early and balanced administration of red blood cells, plasma, and platelets.
Be prepared.
This proactive approach, often triggered by specific criteria, can significantly improve patient outcomes.
Great nuggets to keep in mind as we delve into the details. Let's start with the congenital factor deficiencies, the inherited bleeding disorders. What are the most common ones?
These are inherited conditions where a patient is deficient in one of the coagulation factors. While deficiencies of all coagulation factors can occur, the most frequent and clinically significant are factor VIII deficiency, known as hemophilia A, and factor IX deficiency, also called hemophilia B.
Hemophilia A and B.
Von Willebrand's disease is also very common.
Hemophilia A and B are the ones most people are familiar with. What's important to know about them?
Hemophilia A and hemophilia B are inherited as sex-linked recessive disorders, which means they primarily affect males.
Yep.
The clinical severity of the disease is directly dependent on the measurable level of factor VIII or factor IX in the patient's plasma.
Okay.
For instance, plasma factor levels less than 1% of normal are considered severe disease. Patients with severe hemophilia often experience spontaneous bleeds, frequently into joints, which can lead to crippling arthropathies, as well as intracranial bleeding and deep tissue hematomas.
That sounds awful.
It can be. Those with moderate or mild disease with higher factor levels typically bleed only after trauma or surgery. A fascinating point here is that platelet function is actually normal in hemophiliacs. So immediately after a minor injury or surgery, they might not bleed excessively because they can form a normal platelet plug.
Ah, so the initial plug is fine.
Right. Sometimes the diagnosis isn't even made until a patient's first minor procedure, like a tooth extraction, when delayed or persistent bleeding becomes apparent.
How are these conditions typically treated?
Patients with hemophilia A or B are primarily treated with factor VIII or factor IX concentrate, respectively. Recombinant factor products are generally preferred.
Okay.
The goal is to restore activity levels to specific targets, higher for more severe bleeding. A major complication, however, is the development of inhibitors.
Inhibitors.
Yes, up to 20% of hemophiliacs with factor VIII deficiency can develop these antibodies that neutralize the administered factor. This makes treatment much more challenging, often requiring alternative agents like recombinant factor A and always a multidisciplinary approach for surgical patients.
And what about von Willebrand's disease, often mentioned alongside hemophilia? What's the core issue here?
Von Willebrand's disease, or VWD, is actually the most common congenital bleeding disorder. It's characterized by either a quantitative deficiency or a qualitative defect in von Willebrand factor, or VWF.
The factor we talked about for platelet adhesion.
Exactly.
Yeah.
As we discussed, VWF is crucial for carrying factor VIII in the blood and for normal platelet adhesion to exposed subendothelium, as well as for platelet aggregation, especially under high shear conditions.
What kind of bleeding do you typically see with VWD?
Patients with VWD tend to have bleeding characteristic of platelet disorders, such as easy bruising and mucosal bleeding. Common manifestations include frequent nosebleeds or epistaxis and heavy menstrual bleeding or menorrhagia in women.
Okay.
It's classified into three types depending on the nature of the VWF defect, which influences treatment. For example, milder type I often responds to desmopressin or DDAVP, which helps release more VWF, while severe type 3 usually requires VWF concentrates.
What about factor XI deficiency, also known as hemophilia C? I've heard there's a unique interest in this one.
Factor XI deficiency is an autosomal recessive inherited condition, meaning it affects both males and females, and it's notably more prevalent in the Ashkenazi Jewish population.
Okay.
Spontaneous bleeding is rare with this deficiency. However, bleeding can occur after surgery, trauma, or invasive procedures. It's managed with fresh frozen plasma, or FFP, and antifibrinolytics. What's truly fascinating is that patients with factor XI deficiency generally have only minimal bleeding risk, unless the deficiency is severe, but crucially, they also seem to be protected from thrombosis.
Wow, that's a paradox.
It is. This paradox has led to renewed interest in developing factor XI inhibitors as antithrombotic agents, offering a potential therapeutic avenue that could prevent clots with a lower bleeding risk compared to current anticoagulants.
So that's the genetic side. Now let's turn to acquired hemostatic defects when the body develops problems with clotting. We'll start with platelet abnormalities, both quantitative and qualitative.
Acquired abnormalities of platelets are much more common than the congenital defects we just discussed. These can involve quantitative defects, meaning a problem with the number of platelets, or qualitative defects, where the platelets are present but don't function properly.
Count versus function.
Exactly. Some patients may even have both.
For quantitative defects or thrombocytopenia, what are the primary causes?
Quantitative defects can stem from three main issues: failure of platelet production, shortened platelet survival, or sequestration.
Production, survival, sequestration.
Failure of production typically results from bone marrow disorders, such as leukemia, or from chemotherapy drugs, radiation, or certain viral infections. If a patient with a quantitative abnormality requires treatment due to symptoms or an invasive procedure, platelet transfusion is typically used.
Okay.
Shortened platelet survival is seen in conditions like immune thrombocytopenia, or ITP, and disseminated intravascular coagulation, or DIC.
Let's focus on immune thrombocytopenia, or ITP, first. What is it and how is it managed?
ITP can be either idiopathic, meaning primary, with no clear cause, or secondary, where it's associated with other autoimmune disorders or viral infections, including HIV.
Okay.
Secondary ITP often presents with a very low platelet count, alongside characteristic skin manifestations like petechiae and purpura and nosebleeds. Initial treatment usually involves corticosteroids or intravenous gamma globulin.
Right.
Importantly, platelet transfusions are generally not needed unless there's central nervous system bleeding or active, severe bleeding from other sites, because the transfused platelets usually have a very short survival in these patients due to the immune destruction.
And heparin-induced thrombocytopenia, or HIT. This one sounds particularly dangerous because it can cause both low platelets and clots.
HIT is a critical form of drug-induced immune thrombocytopenia. It's an immunological event where antibodies form against platelet factor 4, or PF4, during exposure to heparin.
Okay.
These antibodies then affect platelet activation and endothelial function, leading to both thrombocytopenia, a drop in platelet count, and, paradoxically, intravascular thrombosis.
Low platelets and clots. That's bad.
Very dangerous. The platelet count typically begins to fall 5 to 7 days after heparin is started, but if the patient has been re-exposed to heparin, the drop can occur much faster, within 1 to 2 days.
Right.
You should suspect HIT if the platelet count falls below 100,000, or if it drops by 50% from the patient's baseline while they are receiving heparin. Critically, HIT is characterized by a high incidence of thrombosis, which can be either arterial or venous.
So how do you diagnose it, given these complexities? And what's the treatment?
The 4T scoring system is used to assess the pre-test probability of HIT. Laboratory testing includes an anti-PF4 heparin, but more specific functional assays like the serotonin release assay are often needed for confirmation.
Okay.
Treatment requires immediate action. Stop all heparin and begin an alternative anticoagulant. Simply stopping heparin is not enough to prevent the associated thrombosis.
Crucial point.
The alternative anticoagulants are primarily direct thrombin inhibitors.
And what about thrombocytopenic purpura, or TTP, and hemolytic uremic syndrome, HUS? They sound similar but have key differences.
They are disorders where thrombocytopenia results from platelet activation and the formation of platelet thrombi. In TTP, large von Willebrand factor molecules interact with platelets due to an inhibition of a specific enzyme, ADAM-S13.
Ah, the enzyme defect.
The TTP is classically characterized by a pentad of symptoms: thrombocytopenia, microangiopathic hemolytic anemia, fever, and renal and neurologic signs. The presence of fragmented red blood cells, or schistocytes, on a peripheral blood smear is a key diagnostic aid. Treatment for acute TTP is urgent plasma exchange.
Okay. And HUS?
Hemolytic uremic syndrome, or HUS, often occurs secondary to a specific Shiga toxin-producing E. coli infection. In HUS, the ADAM-S13 enzyme is usually normal, and it's typically associated with a significant degree of renal failure.
So those are the quantitative defects with decreased survival. What about platelet sequestration?
Sequestration is another cause of thrombocytopenia, typically involving the trapping of platelets in an enlarged spleen, a condition often seen with portal hypertension.
Hypersplenism.
Right. While the total body platelet mass is essentially normal in these patients, A much larger fraction of their platelets are simply held within the enlarged spleen. Bleeding is often less severe than what might be anticipated from the platelet count alone, because these sequestered platelets can, to some extent, be mobilized when needed.
Moving on to qualitative platelet defects or platelet dysfunction, which can occur even with the normal platelet count. This seems particularly important because, as you said, 80% of clot strength is related to platelet function.
It is indeed. Impaired platelet function often goes hand in hand with thrombocytopenia, but it can also occur when the platelet count is perfectly normal. Because platelets have a lifespan of only 7 to 10 days, they are highly susceptible to impairment by various medical disorders like uremia and by common medications.
Right.
Massive transfusion of blood products can also lead to impaired platelet aggregation.
And what about the drugs we mentioned earlier? How do they specifically cause dysfunction?
Medications are a significant cause. Aspirin works by irreversibly acetylating an enzyme, permanently affecting platelet function for its lifespan. Clopidogrel and prasugrel cause selective irreversible inhibition of ADP-induced platelet aggregation.
Okay.
Given this, determining the timing of surgery for patients on these drugs is a critical and often challenging question. The general recommendation for elective procedures is still to wait approximately 5 to 7 days after the drug is stopped to allow for regeneration of functional platelets.
Right, the 5 to 7 day rule.
For urgent surgeries, the timing is less clear. Emerging functional tests, such as thromboelastography or TEG with platelet mapping, are becoming available to better guide decisions on when to operate or if platelet transfusions might be indicated.
Now let's turn to acquired hypofibrinogenemia, focusing first on disseminated intravascular coagulation, or DIC. This sounds like a system gone completely haywire, with both clotting and bleeding.
DIC is indeed a severe acquired syndrome characterized by systemic activation of the coagulation pathways. This leads to excessive thrombin generation and the widespread formation of diffuse microthrombi throughout the microcirculation.
Tiny clots everywhere.
The critical consequence is the consumption and depletion of both platelets and coagulation factors, resulting in the classic clinical picture of diffuse bleeding.
Uses everything up.
Exactly. If severe, these microthrombi can cause microvascular ischemia and subsequent end organ failure.
What causes DIC? It sounds like it can be triggered by many things.
A wide range of conditions can predispose a patient to DIC, and identifying the underlying condition is essential for diagnosis. For instance, severe trauma, widespread malignancy, severe organ injury like pancreatitis, liver failure, certain vascular abnormalities, and very commonly sepsis can all trigger DIC.
Okay.
Sepsis is a really big one.
How is DIC diagnosed and how do you treat this chaotic condition?
The diagnosis of DIC is based on identifying an inciting etiology combined with specific laboratory findings. Thrombocytopenia, prolongation of the prothrombin time, a low fibrinogen level, and elevated fibrin markers like D-dimers.
Right, the lab picture.
The most important aspects of treatment are addressing the underlying causative medical or surgical problem and maintaining adequate organ perfusion. For patients with active bleeding, hemostatic factors should be replaced, typically with fresh frozen plasma or FFP, and cryoprecipitate if fibrinogen levels are very low.
What about primary fibrinolysis as another cause of acquired hypofibrinogenemia?
Primary fibrinolysis is another cause of an acquired hypofibrinogenemic state in surgical patients, distinct from trauma. This can occur, for example, after prostate resection when urokinase is released, or in patients undergoing extracorporeal bypass procedures.
Okay.
Treatment in these cases involves antifibrinolytic agents, such as tranexamic acid, which work by inhibiting plasminogen activation.
Let's discuss coagulopathies tied to specific conditions, starting with liver disease. This one seems particularly complex, with both bleeding and clotting risks at the same time.
It is, and it's a fascinating area where traditional thinking has been challenged. The liver plays an absolutely central role in hemostasis because it's responsible for synthesizing many crucial coagulation factors, including the vitamin K-dependent factors, fibrinogen, and factor V.
Right.
It also produces important natural anticoagulant proteins like antithrombin III and protein C and S.
So liver disease leads to decreased production of these factors, which would naturally lead to bleeding, right?
That's the traditional view. However, liver disease leads to a decreased production of both procoagulant factors and the natural anticoagulant proteins.
Both sides.
This disturbs a delicate balance, creating a complex paradigm where patients have both an increased bleeding risk and an increased thrombotic risk. It's a contradiction to what one might initially assume.
Fascinating.
The most common abnormalities are thrombocytopenia, or low platelet count, and impaired humoral coagulation function, typically seen as prolonged prothrombin time, or PT, and international normalized ratio, or INR.
And for treatment, when is correction actually needed for bleeding and liver disease?
Before initiating any therapy, it's essential to strongly consider the actual need for correction. Generally, correcting solely based on a low platelet count or prolonged INR is discouraged if the patient isn't actively bleeding or undergoing an invasive procedure.
Treat the patient, not the number.
Exactly. When required, platelet transfusions are the mainstay, but their effect is often short-lived. For prolonged PT-INR, FFP is typically used. If fibrinogen levels are below 200 milli-GDL, cryoprecipitate can be helpful.
Now let's turn to the coagulopathy of trauma, or TICEC. This has really shifted in understanding over the years, hasn't it?
Yes, the understanding of trauma-related coagulopathy has undergone a significant paradigm shift. Traditional teaching attributed its development primarily to acidosis, hypothermia, and the dilution of coagulation factors from fluid resuscitation.
The lethal triad.
Right. However, recent data have clearly shown that over a third of severely injured patients arrive at the hospital already having laboratory evidence of coagulopathy. This distinct phenomenon is now termed trauma-induced coagulopathy, or TEC.
And this isn't just standard DIC or dilution. What are the proposed mechanisms behind TEC?
That's right. It's crucial to stress that TEC is a separate and distinct process. Several mechanisms have been proposed. One is activated protein C-mediated clotting factor deactivation.
What are TC again?
Another is endothelial injury, which can lead to autoheparinization as substances are shed into the circulation. Platelet dysfunction also plays a significant role. And finally, hyperfibrinolysis, which is excessive clot breakdown.
Multiple hits.
While hemorrhagic shock was previously thought to be essential, more recent evidence challenges this, showing that severe traumatic brain injury can induce TEC even without shock.
This is a really nuanced point. You also mentioned the converse of hyperfibrinolysis, something called fibrinolytic shutdown. What is that, and why is it deadly?
This is a critical nuance for professionals in the field. While hyperfibrinolysis excessive clot breakdown is certainly dangerous and leads to death from hemorrhage, fibrinolytic shutdown is also associated with increased mortality after trauma, often from late causes like multiple organ failure.
So too little breakdown is also bad.
Exactly. A large multi-center study of trauma patients elegantly demonstrated this spectrum. Patients with intermediate fibrinolytic activity on admission had the lowest mortality. Those with fibrinolytic shutdown had increased mortality, and those with hyperfibrinolysis had the greatest mortality, typically due to hemorrhage. This shows the delicate balance in how both extremes can be lethal.
Let's move to acquired coagulation inhibitors. What's an important one to be aware of, and it has a fascinating paradox.
Among the most common acquired coagulation inhibitors is the antiphospholipid syndrome, or APLS. This syndrome includes the presence of the lupus anticoagulant and anticardiolipin antibodies.
Okay.
These antibodies are strongly associated with both venous and arterial thrombosis. If a patient presents with recurrent thrombosis, evaluation for APLS is crucial.
Right.
The hallmark paradox of APLS, which is a great aha moment for understanding this condition, is a prolonged APTT in vitro, meaning in laboratory tests, but an increased risk of thrombosis in the body, in vivo.
Lab test looks like bleeding, but patient clots.
Precisely. It's counterintuitive, but vital to recognize.
That's a perfect lead into segment 3, the art and science of blood management. Anticoagulation, transfusion, and testing. Any anticoagulant therapy carries a risk of spontaneous bleeding, whether it's heparin, low molecular weight heparins, warfarin, factor XI inhibitors, or direct thrombin inhibitors.
Indeed, that risk is inherent. For example, with heparin, the risk of spontaneous bleeding is generally reduced when it's administered as a continuous infusion. Low molecular weight heparins, or LMWHs, offer more reliable therapeutic levels, which makes them an attractive option.
Easier to manage sometimes.
While routine monitoring isn't always necessary for LMWHs, if it is required, for instance in patients with renal insufficiency, the drug effect should be determined by measuring anti-XA activity.
Warfarin management sounds like a particularly complex dance, given all its interactions. What's the biggest challenge there?
Warfarin is used for long-term anticoagulation in a variety of conditions like DVT, PE, and with prosthetic heart valves. Its dosing is quite sensitive due to its interaction with the P450 enzyme system, meaning many other medications, and even diet can alter its effect.
Lots of variables.
A lot.
And what about reversing warfarin in urgent situations, like for emergency surgery?
Warfarin use significantly increases morbidity and mortality in acutely injured or emergency surgery patients. However, rapid reversal of its effects can dramatically reduce these complications.
Okay.
There are several options for reversal, including vitamin K, plasma, and prothrombin complex concentrate, or PCC. Guidelines recommend that patients with major or life-threatening bleeding due to warfarin receive reversal with both vitamin K and a rapid reversal agent like PCC.
Both vitamin K and PCC.
Vitamin K is crucial to sustain the reversal effect, as plasma and PCCs have shorter half-lives.
And how do PCCs compare to plasma for reversal?
Studies have shown that PCC is superior to plasma in terms of speed of reversal and a decreased risk of fluid overload. While PCC is more costly, it's equivalent to plasma in terms of adverse events.
Faster, less volume.
Right. PCC is available in two forms: 3-factor PCC, containing factors 2, 9X, and X, and 4-factor PCC, which includes factors 2, 7, 9XX. 4-factor PCCs have consistently shown more reliable correction of INR.
Now, the direct oral anticoagulants, or DOACs, present a newer challenge because of monitoring and reversal difficulties. What are the latest developments there?
They certainly do. DOACs, which include direct thrombin inhibitors like dabigatran and factor Z inhibitors like rivaroxaban and apixaban, lack a readily available method to detect the precise degree of anticoagulation.
Still a challenge.
This makes managing bleeding or preparing for emergency surgery particularly difficult. However, there's been a significant breakthrough with etorucizumab, an approved monoclonal antibody fragment that specifically binds to dabigatran and is shown to normalize laboratory tests.
A specific reversal agent.
For dabigatran, yes. For factor C inhibitors, specific antidotes like andexanet alpha are in trials or newly approved, but until widespread, 4-factor PCCs are often used as a temporary measure.
What are some common bleeding complications for patients on anticoagulants?
Common bleeding complications include hematuria, soft tissue bleeding, intracerebral bleeding, skin necrosis, and various forms of abdominal bleeding, such as rectus sheath hematomas.
Can surgery be performed on anticoagulated patients without full reversal?
Increasingly, experience suggests that surgical treatment can be undertaken without full reversal of anticoagulation, depending on the specific procedure.
Really?
For example, if the APTT is less than 1.3 times the control value in a heparinized patient, or if the INR is less than 1.5 in a patient on warfarin, full reversal of anticoagulation therapy might not be necessary.
If the levels are low enough.
Right. However, meticulous surgical technique and very close observation throughout the post-operative period are absolutely mandatory.
Can't be sloppy.
Absolutely not. Certain surgical procedures, like those on the central nervous system and the eye, should never be performed if the patient is anticoagulated due to the severe consequences of even minor bleeding.
Okay.
For emergency reversal of heparin, protein sulfate is effective, but clinicians must be aware of potential adverse reactions. For warfarin, discontinuation, or plasma PCC for emergent situations are the mainstays.
Perioperative bridging of anticoagulation seems like a growing challenge. How is that managed now?
It's an increasingly common and complex problem. While earlier guidelines suggested perioperative bridging, often with LMWH, more recent studies have introduced a nuanced perspective, finding an increased risk of major bleeding without a significant change in the rate of thromboembolism when comparing bridging to no bridging for elective operations.
So bridging might cause more harm sometimes.
It potentially can increase bleeding risk without clear benefit in some cases. Therefore, the current approach emphasizes a very careful balance of the patient's individual risks for bleeding versus venous thromboembolism when deciding on bridging.
What about coagulopathy during cardiopulmonary bypass, or CPB, in cardiac surgery? How does that system interact with this complex coagulation?
Cardiopulmonary bypass profoundly alters hemostasis. When a patient's blood comes into contact with the circuit tubing and membranes, it activates platelets and clotting factors, as well as inflammatory cascades.
A big trigger.
Huge trigger. This leads to excessive fibrinolysis and a combination of both quantitative and qualitative platelet defects. This multifactorial coagulopathy is further compounded by the sheer stress within the system, induced hypothermia, hemodilution from fluids, and the necessary anticoagulation.
Wow, a perfect storm.
Pretty much. Activated clotting time, or ACT, is used to monitor during bypass, and thromboelastography, or TUG, is considered a better tool for estimating the extent of coagulopathy and anticipating transfusion requirements if bleeding is present. Antifibrinolytics, like tranexamic acid, are often administered at the time of anesthesia induction to reduce postoperative bleeding and the need for reoperation.
Now, let's talk about transfusion therapy. from history to modern practice. It's fascinating how much this has evolved, from whole blood to components and back again.
The acceptance of human blood replacement therapy began in the late 19th century. A major breakthrough came in 1900 with Landsteiner's identification of the major A, B, and O blood groups, which allowed for widespread use.
The ABO grouping, fundamental.
Then, in 1939, Levine and Stetson introduced the concept of RH grouping. These and other advances in blood product preservation, storage, and infectious disease screening laid the foundation for modern transfusion medicine.
And there was a big shift from whole blood to component therapy, right?
Exactly. Whole blood was the standard for transfusions until the late 1970s. Then component therapy began to take prominence. This change was partly driven by blood bank economics, as it allowed for more efficient use of donated blood by providing specific products for specific deficiencies, like red blood cells for anemia, platelets for thrombocytopenia, or plasma for clotting factor deficiencies.
Made sense logistically.
However, this shift was implemented across all patient populations simultaneously, without extensive clinical studies to fully assess its ramifications in different settings.
But now whole blood is seeing a resurgence.
Yes, interestingly, whole blood transfusion, often considered the ultimate balanced transfusion product, is making a resurgence, particularly for the resuscitation of acute hemorrhage in both military and civilian practice, though civilian access remains limited.
Let's quickly review the essentials of typing and cross-matching.
Routine compatibility checks establish ABO and RH serologic compatibility. A major cross-match is performed between the donor's red blood cells and the recipient's serum.
Okay.
For RH-negative recipients, ideally, only RH-negative red blood cells should be transfused. However, if RH-negative blood isn't available, RH-positive red blood cells can be administered, with a critical exception. They should not be given to RH-negative females of childbearing age due to the risk of sensitizing them to the RH factor, which could cause problems in future pregnancies.
Very important exception.
Critical. In emergency situations, universal donor O-negative red blood cells and type AB plasma can be transfused. Due to a shortage of type AB plasma, low anti-B titer type A plasma has become widely adopted for emergency uncross-matched transfusions, as it's compatible with the vast majority of recipients.
Let's delve into the specific blood products, starting with red blood cells and the concept of the storage lesion.
Red blood cells, or RBCs, are still the traditional product of choice for most clinical situations requiring resuscitation. They are prepared as concentrated suspensions by removing most of the plasma, reducing but not eliminating reactions. With modern storage solutions, their shelf life is now up to 42 days.
42 days.
The storage lesion refers to the changes that occur in red blood cells during storage, which can significantly impact the inflammatory response and the incidence of multiple organ failure in recipients.
So older blood isn't as good.
Functionally, it can be different. During storage, there's a reduction in intracellular substances that impair oxygen offloading from hemoglobin, and the red cells themselves can become less flexible, impairing flow through tiny vessels.
So age of the blood really matters. What about cryopreserved red blood cells or leukocyte-reduced RBCs?
Cryopreservation of red blood cells involves storing them at ultra-low temperatures, extending their shelf life to 10 years while maintaining cellular viability.
10 years.
But their major limitation for emergency use is the thawing and preparation time, which takes about 90 minutes.
Not great for trauma.
Not ideal. Leukocyte-reduced RBCs undergo filtration to remove most white blood cells, which prevents almost all febrile, non-hemolytic transfusion reactions and significantly reduces the transmission of cytomegalovirus. In many Western nations, leukocyte-reduced red blood cells are now the standard transfusion product.
Next, platelet concentrates. When are they indicated?
Platelet transfusions are indicated for thrombocytopenia caused by massive blood loss, by inadequate platelet production, or by qualitative platelet disorders. Platelets are stored at room temperature with constant agitation to prevent clumping and have a short shelf life of only 5 days due to the risk of bacterial overgrowth.
Only 5 days.
A therapeutic level of platelets is generally considered to be in the range of 50,000 to 100,000 per microliter, but this is highly dependent on the clinical situation and the patient's bleeding status. Recent evidence suggests that earlier use of platelets may improve outcomes in actively bleeding patients.
What about plasma products? We have fresh frozen plasma, thawed plasma, liquid plasma, and even a rediscovered freeze-dried plasma.
Plasma is a crucial source of the vitamin K-dependent factors and factor V, and it carries similar infectious risks as other component therapies. Fresh frozen plasma, or FFP, is frozen within hours and can be stored for up to 2 years, but requires 20 to 30 minutes to thaw.
Thawing time again.
Thawed FFP can be relabeled as thawed plasma, immediately transfusible and stored for up to 5 days. Liquid plasma is never frozen and can be stored for up to 26 days. And in vitro studies suggest it has a better hemostatic profile than thawed plasma.
Okay.
Freeze-dried or lyophilized plasma, or FTP, has indeed been rediscovered as an ideal resuscitation product for remote and austere environments.
Freeze-dried plasma. Wow.
It's a powder, shelf-stable for up to 2 years at room temperature, and can be quickly reconstituted within minutes, offering a significant logistical advantage, especially in military settings. Modern FTP is also pathogen-reduced.
Let's discuss tranexamic acid, or TXA. This has become quite important in trauma care.
Tranexamic acid, or TXA, is an antifibrinolytic agent. Its mechanism is to inhibit both plasminogen activation and plasmin activity, essentially stabilizing the clot by preventing its premature breakdown.
Stops the cleanup crew too early.
In a way. At therapeutic concentrations, it does not affect platelet count, aggregation, or other coagulation parameters. It's increasingly used to treat injured patients in both civilian and military settings, and the Eastern Association for the Surgery of Trauma, or EAST, conditionally recommends its early use as a hemostatic adjunct in severely injured patients. While beneficial, it should not be used in patients with active intravascular clotting.
Now to the why of transfusion. Indications for replacement of blood and its elements. Let's start with improving oxygen carrying capacity. Why is it surprising that RBC transfusion doesn't always directly correlate with enhanced cellular oxygen delivery?
The primary function of red blood cells is to improve oxygen carrying capacity. However, despite this obvious association, there's surprisingly little direct evidence that transfusion of red blood cells actually equates to enhanced cellular oxygen delivery and utilization.
Really? Why not?
The reasons for this apparent discrepancy are linked to the changes that occur in red blood cells during storage, what we call the storage lesion.
Ah, the storage lesion again.
The decrease in specific compounds within stored RBCs impairs oxygen offloading from hemoglobin, and the deformation of the red cells can impair microcirculatory perfusion, meaning they don't move as easily through tiny vessels.
That challenges a pretty long-standing dogma. What about transfusion triggers for anemia, especially in non-actively bleeding patients? When do we truly need to transfuse?
This is where practice has significantly evolved. A pivotal 1988 NIH consensus report challenged the traditional dictum of automatically transfusing if hemoglobin was less than 10 GDL.
The old 1030 rule.
Right. This was reinforced by a randomized controlled trial in critically ill patients, which demonstrated that maintaining hemoglobin levels between 7 and 9 GDL had no adverse effect on mortality. In fact, for certain patient groups, a restrictive strategy actually resulted in lower mortality.
Lower is better sometimes.
In many stable patients, yes. Current guidelines from the American Association of Blood Banks, or AABB, recommend a minimum hemoglobin threshold of 7 GDL for hemodynamically stable patients. For cardiac orthopedic surgery or pre-existing cardiovascular disease, the recommended threshold is 8 GDL.
Okay, 7 or 8 depending.
Both guidelines emphasize the importance of considering patient-specific characteristics and the overall clinical context. In practical application, for symptomatic anemia, it's generally recommended to transfuse 1 RBC unit at a time. Isolated asymptomatic anemia is rarely an indication for RBC transfusion by itself.
Beyond oxygen carrying capacity, volume replacement is obviously a common indication for blood transfusion in surgical patients.
Yes, it's perhaps the most common indication, but quantifying the actual intravascular volume deficit can be difficult to determine accurately and quickly. While hemoglobin or hematocrit levels are frequently used to assess blood loss, they can be misleading in the face of acute rapid loss.
Labs lag behind.
Exactly. Both the total amount of blood lost and the rate at which it's lost are critical factors. For significant blood loss, a balanced resuscitation approach is required, which includes not just red blood cells, but also fresh frozen plasma and platelets.
This leads us perfectly into new concepts in resuscitation and the dramatic shift in paradigms in trauma care. We used to have a very sequential approach to fluids and blood.
Indeed, traditional resuscitation algorithms, widely used since the 1970s, advocated a sequential approach, starting with crystalloid fluids, followed by packed red blood cells, and then only later, if needed, plasma and platelet transfusions.
Fluids first, then blood.
This practice, however, lacks strong clinical data to support it. Recently, the damage control resuscitation, or DCR strategy, has become the standard for treating substantial traumatic hemorrhage. DCR emphasizes simultaneous measures to achieve mechanical hemorrhage control and rapid maneuvers that promote hemostasis.
So it's a more holistic approach. What are its core components and why the shift?
DCR has four basic components. First, it advocates for permissive hypotension, allowing for a slightly lower blood pressure to prevent clot dislodgement and reduce ongoing bleeding. Second, it minimizes crystalloid-based resuscitation, as excessive use can exacerbate bleeding by diluting clotting factors.
Limits the crystalloid.
Third, it involves the immediate release and administration of predefined balanced blood products, red blood cells, plasma, and platelets in ratios similar to those found in whole blood. And finally, it incorporates the early use of hemostatic adjuncts like TXA.
Balanced ratios early.
The rationale is compelling. Many trauma patients arrive at the hospital already coagulopathic, and this early coagulopathy is a significant risk factor for death. The traditional definition of massive transfusion as 10 or more units of red blood cells in 24 hours is now recognized as arbitrary and insufficient.
Right, 10 and 24 is too late.
Newer definitions focus on the rate of transfusion, with the critical administration threshold, or CC3 units of red blood cells within 60 minutes, being a superior predictor of mortality.
CCAT score.
Okay, it identifies high-risk patients much earlier.
And the PROM-MTT and PROP-UR trials seem to be landmark studies for these high ratios, providing the evidence for DCR.
Absolutely. The shift to DCR began with military data showing reduced mortality with high plasma to RBC ratios. The prospective PROM-MTT study found that hemorrhagic death occurred rapidly, and increased plasma to RBC and platelet to RBC ratios were significantly associated with reduced 6-hour mortality.
6 hours is key.
The landmark PROP-PR trial randomized 680 bleeding trauma patients, comparing a 1.1.1 ratio of plasma, platelets, and red blood cells versus a 1.1.2 ratio. While overall mortality wasn't significantly different, the 1.1.1 group had significantly decreased mortality due to hemorrhage at 24 hours, and more patients achieved hemostasis.
1.1.1 stopped the bleeding better.
Essentially, yes. Importantly, despite initial fears, there was no increase in inflammatory complications. This evidence led to the Eastern Association for the Surgery of Trauma, or EAST, guideline recommending high and balanced ratios of plasma and platelets to red blood cells for severely injured trauma patients.
Beyond just replacing volume, what are the mechanisms behind the benefits of DCR?
The benefits are complex. Plasma resuscitation has been shown to reverse endothelial injury in animal models, particularly by repairing the endothelioglycocalyx layer, or EGL, which is the primary determinant of vascular permeability.
The EGL.
The inner lining of the vessel. Hemorrhage causes EGL shedding and increased permeability. Traditional crystalloid resuscitation increases hydrostatic pressure without repairing the EGL, contributing to widespread edema.
Makes sense.
Plasma, on the other hand, appears to repair the EGL, thereby limiting extravascular leakage and edema. This reduced edema and inflammation are linked to fewer complications. Strong correlations exist between increasing circulating levels of glycocalyx components and trauma severity, coagulopathy, and mortality.
Implementing DCR in practice must require significant logistical effort from trauma centers.
It absolutely does. It's essential that trauma centers have established mechanisms to quickly deliver these blood products in the correct amounts to critically injured patients. This includes immediate blood bank notification for urgent needs, early initiation of 1.1.1 ratios of RBCs, FFP, and platelets, minimizing crystalloid infusion, and rapid point-of-care lab tests.
Massive transfusion protocols.
Exactly. Early prediction models for massive transfusion are crucial due to limited blood supply. The assessment of blood consumption, or ABC score, is a simplified tool using immediately available data like heart rate, blood pressure, fast exam findings, and mechanism of injury. It's validated to predict massive transfusion and identifies high-risk patients early.
Pre-hospital transfusion sounds like taking the hospital to the patient.
It truly is, and it's a critical innovation. Earlier initiation of appropriate therapy significantly improves outcomes for bleeding patients. Studies have shown that moving ready-to-transfuse plasma into the emergency department and using it as a primary resuscitation fluid led to decreased overall blood product use and increased 30-day survival.
Plasma in the field.
Pre-hospital retrospective studies involving helicopter transport have found that in-flight plasma transfusion was associated with less deranged physiology upon admission and reduced early mortality. Pre-hospital RBC transfusion has shown similar findings. In the military setting, the implementation of pre-hospital transfusion protocols, combined with more rapid transport times, was also associated with reduced mortality.
And whole blood resuscitation, back to the future, as you said.
Yes, the military has extensive experience with whole blood for traumatic hemorrhage resuscitation, dating back to the American Civil War. One key advantage of whole blood versus component therapy is the availability of platelets, which are often difficult to obtain or store in remote and austere settings.
Platelets are the challenge.
Retrospective studies have consistently found that whole blood was associated with improved survival compared to component therapy. Whole blood generally has a higher hematocrit, better clotting factor activity, and a higher platelet count compared to what you get with a 1.1.1 component therapy.
It's naturally balanced.
In vitro studies have shown that the hemostatic potential of whole blood can be preserved for up to 14 days with cold storage. Pilot civilian trials using cross-matched modified whole blood or uncross-matched low-titer whole blood in initial resuscitation have also reported success. It's truly anticipated that whole blood may return as a therapy of choice for initial resuscitation of substantial hemorrhage.
And fibrinogen replacement. It seems particularly important early on, as it's often the first factor to fall.
Fibrinogen is indeed often the first coagulation factor to fall to critically low levels during major hemorrhage. Low systemic concentrations are associated with increased injury severity, more pronounced coagulopathy, and are independently predictive of mortality.
Low fibrinogen is bad news.
Moreover, fibrinogen levels can drop even in the pre-hospital phase, underscoring the need for early administration, either through fibrinogen concentrate, which is not yet FDA approved in the U.S., or cryoprecipitate. Fibrinogen concentrate has significant benefits. It's a lyophilized powder, stable at room temperature, can be quickly reconstituted, and includes viral inactivation steps. Pilot trials are showing feasibility, and larger randomized controlled trials are currently pending.
Moving on to the complications of transfusion, understanding the risks. It's estimated that adverse events occur in about 10% of transfusions, but serious ones are rare.
That's correct. Less than 0.5% of transfusion-related events are serious, and rare deaths primarily stem from transfusion-related acute lung injury, or TRAI, ABO hemolytic transfusion reactions, and bacterial contamination.
TRAI hemolytic reactions, bacteria.
This highlights the careful balancing act in transfusion medicine, weighing the benefits against these potential, though rare, complications.
Let's quickly break down the most common ones.
Febrile non-hemolytic transfusion reactions, or NHTRs, are quite common, occurring in approximately 1% of all transfusions, defined as a temperature increase of more than 1 degree C. These are largely prevented by using leukocyte-reduced blood products.
Leukoreduction helps there.
Bacterial contamination of infused blood is rare but very serious, often leading to sepsis and death in a significant percentage of patients. Most cases are associated with platelets, which are stored at warmer temperatures.
Right, room temp storage.
Allergic reactions are relatively frequent, but usually mild, causing rash or hives. In rare instances, anaphylactic shock can develop. These are treated with antihistamines or epinephrine for serious cases.
Now, the more severe ones, respiratory and hemolytic complications.
Transfusion-associated circulatory overload, or TACO, is an avoidable complication from rapid infusion of fluids, particularly in older patients with heart disease. Symptoms are typical fluid overload, dyspnea, cough, rales. Prevention involves careful monitoring and judicious fluid use.
TACO is volume overload.
Transfusion-related acute lung injury, or TRAL-SRI, is more severe and defined as non-cardiogenic pulmonary edema related to transfusion. It occurs with plasma-containing products. Symptoms include dyspnea, hypoxemia, fever, and bilateral infiltrates. It most commonly occurs within 1 to 2 hours.
TRAL is immune-mediated lung injury.
Exactly. Its incidence has decreased with the reduction of plasma transfusions from female donors. TRALI is usually self-limited with supportive therapy. And the most feared, hemolytic reactions. Acute hemolytic reactions are very serious and can be fatal in up to 6% of cases. They are caused by the administration of ABO-incompatible blood, often from lab or clerical errors.
Wrong blood type.
These immediate reactions cause rapid red blood cell destruction, triggering DIC and acute renal insufficiency. Delayed hemolytic reactions occur 2 to 10 days after transfusion, typically characterized by fever, mild anemia, and jaundice due to a rising antibody titer from a prior exposure.
Okay.
For awake patients, symptoms of acute reactions include pain at the site, facial flushing, back chest pain, fever, respiratory distress, and hypotension. In anesthetized patients, diffuse bleeding and hypotension are key hallmarks.
Got it.
If suspected, the transfusion must be stopped immediately and blood samples sent to the lab.
And finally, disease transmission. How has that been dramatically minimized?
Dramatically so. While rare, diseases like malaria and Chagas's disease can still be transmitted, However, the transmission of hepatitis C and HIV-1 has been minimized by the introduction of highly effective antibody and nucleic acid screening.
Screening is key.
The residual risk among allogeneic donations is now estimated to be less than 1 per 1 million donations. Hepatitis B is around 1 per 300,000. These greatly decreased rates are directly attributable to improved donor selection and extensive testing.
Much safer now.
Emerging pathogen inactivation systems are aiming to further reduce infectious levels of viruses and bacteria, though prion disorders like Creutzfeldt-Jakob disease pose a unique challenge with no current inactivation methods. More recently, there's heightened concern regarding Zika virus transmission by blood product transfusion, especially due to its link to serious birth defects in pregnant women.
Let's move to tests of hemostasis and blood coagulation, the diagnostic toolkit. How do you initially assess hemostatic function?
The initial approach always begins with a careful review of the patient's clinical history, specifically looking for any previous abnormal bleeding or bruising, and a thorough review of their medication use.
History first.
This is then complemented by basic laboratory testing.
What are the conventional coagulation tests like platelet count, PT, and APTT?
Common screening lab tests include platelet count, prothrombin time, or PT, often reported as the International Normalized Ratio, or INR, and activated partial thromboplastin time, or APTT. The normal platelet count is 150,000 to 400,000 per microliter. Major surgical bleeding can occur below 50,000 and spontaneous hemorrhage below 20,000.
Platelet count thresholds.
The PT test measures the function of factors 1, 2, V, 7, and X. Factor 7 is part of the extrinsic pathway, and its short half-life makes the PT best suited to detect vitamin K deficiencies and to monitor warfarin therapy. The INR was developed to make PT results comparable globally.
PT-INR for warfarin.
The APT measures factors 1, 2, V and 8, 9XX, AKN, and 12. It's commonly used to monitor heparin therapy.
APT for heparin.
Beyond warfarin and heparin, many other medications like antiplatelet agents or thrombolytics can significantly impair hemostatic function.
But these conventional tests have limitations, don't they? They don't seem to fully capture the dynamic nature of clotting.
That's a crucial point. While conventional coagulation tests are useful for monitoring warfarin and heparin and reflect the classic intrinsic and extrinsic coagulation cascades, they poorly reflect the status of actively bleeding patients.
They're static tests.
Exactly. This isn't surprising because these tests use only plasma, not whole blood, for their assessment. To better assess the complex and rapidly changing hemostatic function of an actively bleeding patient, many centers have shifted towards whole blood viscoelastic testing.
That's where viscoelastic assays like TEG and ROTEM come in. How do they provide a more dynamic view, and what do they tell us?
These assays are fundamentally different because they monitor hemostasis as a dynamic process, unlike conventional screens. They measure the viscoelastic properties of whole blood as clotting is induced.
Whole blood dynamic process.
The patterns of change over time provide crucial information about the kinetics of clot formation and growth, as well as the strength and stability of the formed clot. This means they can tell us not just if a clot forms, but how strong it is and how quickly it breaks down.
The whole picture. Can you break down the key parameters these tests give us and what they mean clinically?
Absolutely. The first is the R value, or reaction time, which is the time to initial clot formation. An increased R value indicates a deficiency in clotting factors or severe hemodilution, suggesting a need for plasma.
R time for factors plasma?
Next is K time, or clot kinetics, the time needed to reach a specified clot strength. A prolonged K time suggests hypofibrinogenemia or a significant factor deficiency, also addressed with plasma.
K time also factors plasma.
The alpha angle reflects clot acceleration and the interactions of clotting factors and platelets. A decreased angle is seen with hypofibrinogenemia and platelet dysfunction, and it's typically treated with cryoprecipitate or fibrinogen.
Alpha angle for fibrinodecreo.
The maximal amplitude, or MA, is the greatest height of the tracing and represents the overall clot strength. A decreased MA is seen with platelet dysfunction or deficiencies, or low fibrinogen, and is addressed with platelet transfusion and/or cryoprecipitate.
MA for platelets cryo.
Finally, LY30 is the amount of lysis occurring in the clot, representing clot stability. An increased value indicates the presence of fibrinolysis, which might be treated with antifibrinolytics like TXA.
LY30 for lysis TXA. Okay, so these tests measure everything, from initiation to breakdown. That's a significant advantage, particularly in trauma.
It's a huge advantage. TEG and ROTEM are the only tests that measure all dynamic steps of clot formation, from initiation all the way through to eventual clot lysis or retraction. Recent trauma data shows TEG is highly useful in predicting the early transfusion needs for red blood cells, plasma, platelets, and cryoprecipitate.
Predicts transfusion needs.
It can also predict the need for life-saving interventions, mortality, and crucially, it can be used to guide the administration of tranexamic acid to injured patients who are experiencing hyperfibrinolysis. Their graphic displays allow for much more rapid results and can be less expensive than standard coagulation panels. Some centers are now using TEG rather than conventional coagulation tests to evaluate injured patients right in the emergency department.
Now let's bring all of this to the surgical front line in segment 4. Evaluation of excessive intraoperative or postoperative bleeding and how we directly intervene. When a patient is bleeding excessively during or after surgery, what are the broad categories of causes?
Excessive bleeding during or after a surgical procedure can be broadly attributed to ineffective mechanical hemostasis, issues related to blood transfusion itself, undetected hemostatic defects, a consumptive coagulopathy like DIC, and fibrinolysis.
Multiple possibilities.
It's crucial to identify the primary cause. For example, if bleeding is occurring only from the operative field and not from other sites, it usually suggests inadequate mechanical hemostasis, meaning the surgeon needs to find and tie off or cauterize the source.
Surgical bleeding usually means a surgical cause.
Often, yeah.
And massive blood transfusion can actually be a cause of bleeding, which seems counterintuitive.
It is, but it's a well-known phenomenon. Massive blood transfusion is a common cause of thrombocytopenia, and bleeding following it can be due to hypothermia, dilutional coagulopathy from excessive fluid administration, platelet dysfunction, fibrinolysis, or hypofibrinogenemia.
The consequences of transfusion.
Another cause related to blood administration is a hemolytic transfusion reaction. Diffuse bleeding can actually be the very first sign due to the release of platelet-activating substances from the destroyed red blood cells.
Disseminated intravascular coagulation, or DIC, can also occur in the surgical context.
Yes. In the surgical setting, DIC is characterized by systemic activation of the coagulation system. This results in the widespread deposition of fibrin clots throughout the microcirculation, which can lead to microvascular ischemia and potentially multi-organ failure.
Right.
The ongoing activation of the coagulation system consumes and subsequently depletes coagulation proteins and platelets, which can then paradoxically induce severe bleeding complications. Sepsis can also cause severe hemorrhagic disorders due to thrombocytopenia and hemostatic failure.
Now, let's look at direct interventions. Local and topical hemostatic agents. This is where the surgeon actively works to stop the bleeding.
Precisely. It's important to stress that significant surgical bleeding is often due to ineffective local hemostasis. The primary goal is to prevent further blood loss from a disrupted vessel. Hemostasis can be achieved by either interrupting the flow of blood to the involved area or by directly closing the defect in the blood vessel wall.
What are some of the oldest mechanical procedures for stopping bleeding, the fundamentals?
The oldest and often very effective mechanical method is direct digital pressure, applied either directly at the bleeding site or proximally.
Good old pressure.
Examples include applying an extremity tourniquet or performing the Pringle maneuver to control bleeding from the liver. For small vessels, a simple ligature or tie is usually sufficient. For larger pulsating arteries, a transfixion suture, which passes through the vessel wall, is indicated to prevent the ligature from slipping off.
Sutures and ties.
For diffuse bleeding from large areas, such as in trauma, direct pressure applied by packing a wound with gauze or laparotomy pads is often the best method. And for controlling bleeding from cut bone wax can be packed onto the raw surface.
Packing and bone wax. Okay. What about thermal agents, using heat to coagulate?
Thermal agents achieve hemostasis by denaturing proteins, which results in the coagulation of large areas of tissue. Electrocautery is a common example. It generates heat from an alternating current source, which is then transmitted by conduction directly to the tissue, causing coagulation.
Cautery.
Proper amplitude should produce prompt coagulation without arsing, and a negative grounding plate must be placed beneath the patient for proper function. Direct currents and argon gas are also used.
And finally, topical hemostatic agents, the adjuvant arsenal. These are not substitutes for good surgical technique, correct?
Exactly. These agents play a crucial role as adjuncts to facilitate surgical hemostasis, but they are not substitutes for meticulous surgical technique.
Helpers, not replacements.
Their ideal properties include significant hemostatic action, minimal tissue reactivity, non-antigenicity, biodegradability within the body, and ease of sterilization. They're broadly classified into absorbable agents and biologic agents.
What are some examples of these topical agents?
Absorbable agents include gelatin foams like gel foam, oxidized cellulose like Surgicel, and microfibrillar collagens like Apitine. Their mechanisms involve providing a physical matrix for clotting initiation or facilitating platelet adherence and activation.
Gel foam, Surgicel.
Biologic agents include topical thrombin and fibrin sealants. Topical thrombin works by facilitating the formation of fibrin clots. However, a crucial caution here. Thrombin entry into larger vessels can result in systemic exposure, which carries a significant risk of disseminated intravascular clotting or even death.
Don't let thrombin get systemic.
Absolutely critical. Fibrin sealants prepared from cryoprecipitate don't promote inflammation and have proven safe and highly effective in controlling parenchymal bleeding, like from the liver.
So in summary, these are powerful tools but need to be used judiciously.
Precisely. They are adjunctive tools, not replacements for good surgical practice. Their use should be limited to the minimum amount necessary to minimize potential toxicity, adverse reactions, interference with wound healing, and procedural costs.
What an incredible deep dive into the complex world of hemostasis, surgical bleeding, and transfusion. We've gone from the microscopic dance of platelets and clotting factors to the grand strategies of massive transfusion and trauma resuscitation. Understanding these intricate details is truly key to mastering this field.
It's a field constantly evolving, driven by new biological insights and clinical necessity. The body's own system is remarkably resilient, but when it's overwhelmed or defective, modern medicine steps in with an increasingly sophisticated arsenal, always striving for that delicate balance.
So as we wrap up today, let me leave you with this thought-provoking question. Given the incredible complexity and built-in redundancies of the body's hemostatic system and the ever-evolving tools we have to manage bleeding, what will be the next frontier in minimizing blood loss and improving outcomes, especially as we push the boundaries of surgical intervention and trauma care into even more challenging scenarios? Think about the implications of truly synthetic blood that carries oxygen and clots, or even more precise genetic therapies that could fix these deficiencies before they ever cause a problem. What's next for maintaining that delicate balance of life?